Broadcast is now starting. All attendees are in listen-only mode.
Welcome back to the many who are returning and to all who are new here, welcome. We have moved our regularly scheduled in-person journal club to an online platform. Fortunately, our fearless head of the journal club and liaison with the BOC, Brittany, has been working diligently to ensure that we are able to provide these educational opportunities successfully. For additional webinar educational opportunities, you can visit our website and register directly for register directly for the webinars. And our next webinar is going to be held next week. For all athletic trainers who are intending to get live CEUs from the BOC, immediately after the webinar, complete the quiz, which will become available once the webinar has finished. In order to access the quiz, you must remain in the webinar until it closes. 1 hour after the webinar concludes, you will be emailed a link to the evaluation and assessment. You will have 24 hours to complete the assessment. Once you've completed the quiz and the assessment, you will receive an email with a link to download your statement of credit within the next 2 weeks. If you have any questions during the webinar, please submit the question, and we will review the questions at the conclusion of the presentation. Our speaker today is Dr. Rekha Suthar, an interventional pain physician with an anesthesia background, who completed her residency training at Mount Sinai and her fellowship at Case Western. She is presenting today on low back pain in athletes. So I'm going to transition our slides over to her computer, and I will have her take it away.
Right. Thank you, Dr. Hanny, and I thank Relief Sport Medicine and Brittany for arranging all this webinar. Thank you, Dr. Hanny, again for giving me this opportunity to talk. My topic of presentation today is low back pain in athletes. Low back pain is one of the most common cause of playing time loss in athletes, and it is very important for athletic trainer to know the basics of the low back pain in the athletes, because you guys are the one who encountered this problem. You guys are the first person where athletes can go to. Next slide. I have nothing to disclose. So epidemiology. So 10 to 15% of all sports injuries are low back injuries. Sports that have high rates of back pain include gymnastics, diving, weightlifting, golfing, American football, and rowing. Soccer, tennis, football, golf, weightlifting has been reported to be 30 to 40% of having low back pain. One of the studies showed 38% of professional tennis players missed at least one tournament because of low back pain. Now let's discuss some of the common causes of low back pain. Muscle strain or sprain. It is the most common cause of low back pain in college athletes. Another cause is hyperlordosis, where it is related to adolescent growth spurts, where there is an excessive amount of inward curve in the lumbar spine due to axial skeleton grows faster than surrounding soft tissues, resulting in muscular pain. Some of the more serious causes are disc degeneration, herniation, lumbar spinal canal stenosis, spondylolysis, spondylolisthesis, sparse interarticular stress fractures, and facetogenic pain. We will go into each cause in detail one by one. Lumbar strain or sprain. So what is strain? So strain is injury to either a muscle or a tendon. With back strain, muscles and tendons are pulled or torn. It can happen after a single episode of improper lifting, or can happen due to chronic repetitive trauma to the muscles. Sprain is stretching or tearing of a ligament. Ligaments are fibrous bands of tissue that connect two or more bones at the joint and prevents excessive movement of the joint. Now, sprain can happen, may happen secondary to the acute flow to the joint and ligaments can separate, and that can cause pain. Management. So usually management for this kind of pain is usually conservative, rest, ice, anti-inflammatory medications, and progressive return to activity as tolerated by the athlete. Pain should guide to progress the activity by athlete. Imaging is usually not warranted for this kind of pain if it is short term, but if patient has persistent pain or neurological symptoms or radicular type pain or clinical suspicion for more serious pathology, then imaging is warranted. Let's switch the gear to a little bit more serious pathology, lumbar disc displacement. What is disc? So disc or intervertebral disc. These are the jelly-like materials that are situated in the spine, throughout the spine, in between the vertebral body. Now, disc has two layers. The outer layer here, it is made of a fibrocartilaginous tissue called annulus pulposus, and in the center, it is situated nucleus pulposus. It is a gel-like material. What is the function of the disc? Number one, they separate the vertebrae. Number two, it provides surface area for the shock-absorbing gel of the nucleus pulposus, which is the inner layer of the disc. And this nucleus pulposus, what it does, it distributes the hydraulic pressure in all directions under compressive loads. Epidemiology of lumbar disc displacement. So sports that require repetitive flexion and compression, such as football, ice hockey, basketball, soccer, are often associated with lumbar disc herniation. To just give you an idea of how much compressive load these athletes would experience, I found these studies where they studied the compressive load in L4, L5 motion in football players and competitive weightlifters, which was 8,600 Newton and 17,000 Newtons respectively. If we do half squatting lifting of a weight about 1.6 times of a body weight, the compressive load across the L3, L4 motion segment would be 10 times the body weight, would be 7,000 Newton or 700 kilograms. Now terminology. So disc degeneration. Disc degeneration is where disc loses the hydration and it flattens. Disc herniation is disc extending beyond the end plate margin. Focal disc herniation is less than 25% extending beyond the end plate margin. Broad base would be the 25 to 50% of the circumference of the disc. What is Schmall's node? Schmall's node is focal herniation into adjacent vertebral end plates, one of the signs of advanced degenerative changes. Protrusion is a localized disc herniation. Right here on the right side in the picture, you can see the base is wider than the apex, and that's called the protrusion. Extrusion is a localized disc herniation where diameter of the disc fragment from its base to apex is wider at the base. And sequestrate. Sequestrate is a disc material that is completely separated from the parent disc and can go into the spinal canal and can cause compression. Here is the example of the protrusion and extrusion. This is the image of the MRI. On the left side, this is the axial cut, and which is the protrusion, putting pressure on the right side nerve root. The right side of the slide, this is the sagittal cut of the MRI, and this is the example of the extruded disc. This is the slide just to give you an idea of what this degeneration looks like. So on the left side of the slide, you can see there's a normal disc, degeneration, bulging, herniated disc. Here on the right side, this is how it looks in axial cut. This is a normal disc, with normal 2 layers. And here is a herniated disc causing compression of the nerve root on the right side. And here is another example of degenerated disc where there's a rim lesion in the outer layer of the disc and there is a tear of the nucleus pulposus and causing the pain. How is it diagnosed? So diagnosis is mainly based on history, physical exam, and imaging. How would this patient present to you? So patients usually have persistent low back pain. They may or may not have radiating pain down to the leg. Pain usually worsens with the activity that increases the intradiscal pressure, that is straining. They would usually complain about pain while axial loading, sitting with forward flexion, bending forward, that is, coughing and sneezing. And pain usually improves with recumbency, that is, leaning, resting, reclining. These patients usually have dermatomal paresthesia, meaning tingling and numbness, depending on the nerve root that they have compression on, and they may have myotomal weakness, meaning that whatever the muscle group is affected, they may show the weakness in that muscle group. If patient has non-dermatomal pain, kind of going to whole leg or up to the thigh, then there may be another cause of the pain like sacroiliac joint or facet joints. Here is a slide showing just to give you an idea about intradiscal pressure. So the position that causes the most intradiscal pressure would be leaning forward with weights, which is 380 kilopascal, followed by leaning forward with weights, which is 340 kilopascal. And here you can see laying down with bending knees or laying flat decreases the intradiscal pressure, and that's why patient will feel relief during having these positions. Physical exam, you'll see tenderness to palpation on the affected area. Sometimes you may see muscle spasm, you can feel it in the paravertebral region. Decreased range of motion of the spine to flexion and extension. And you can also check the provocative test to see if the pain is due to the disc herniation. Also, every time you do the physical exam, evaluate signs for red flags like fever, chills, any night pain, any bowel or bladder incontinence, or any genital numbness. That would be the signs of cauda equina syndrome, and which requires urgent attention. I'll briefly talk about provocative tests. So first of all, a straight leg raise test. In this test, the patient raises the affected leg up, and patient would have pain in the leg as well as in the back between 30 to 70 degrees of hip flexion. Lasek test. In Lasek test, it is similar to straight leg raise test, where if we do the dorsiflexion in straight leg raise, patient's pain worsens. And these tests are suggestive of lumbar radicular pain. Other test is femoral nerve stretch test, where patient lies prone, knee is passively flexed, and hip is passively extended, and test is positive if patient feels pain in the anterior thigh. SOM test. In this test, have patients seated with hands behind the back to achieve a neutral curvature of the spine. First step to have patient slump at the thoracic and lumbar spine. If that does not cause pain, ask patient to touch the chest to chin to chest, and straighten the knee. That will stretch the nerves and can cause a pain, which will be a positive test. Diagnostic images. So diagnostic imaging can start from X-rays. X-rays do not show any soft tissues, but can show the thinning of the disc, can show narrowing of the disc in between two vertebral bodies. The gold standard imaging test for this kind of pain is MRI. MRI provides sharper distinction between different varieties of soft tissues, can tell you which nerve is being compressed, and also gives us the idea of the central canal as well. CT scan is good at showing bones. It is usually reserved for patients who have contraindication to MRI. Here on the right side, these are three pictures of the MRI. The first two pictures are sagittal sequences T2 and T1, and you can see here between 3 and 4, the disc is nice and gray. Between 4 and 5 and S1, disc is like darker. This means that means a degenerated disc, and you have the protrusion over here. Treatment. So usually the treatment starts from the conservative. So physical therapy would be the first thing to try. Then some pharmacological treatments include anti-inflammatory medication, some steroids, oral steroids, some muscle relaxers, and membrane stabilizers. Membrane stabilizers are the medication that decrease the nerve signals, which are hyperactivated when you have the nerve compression from the lumbar disc herniation. So these are the medication which slows down the signals going to the brain, and that's how they can help with the pain. The other treatment option is interventional pain management, which I do on a daily basis. And the last resort is the surgical treatment. I want to talk about lumbar spinal stenosis briefly, because lumbar spinal stenosis and lumbar disc degeneration, herniation goes hand in hand, and patient can have lumbar spinal stenosis from the lumbar disc herniation. So definition is narrowing of the central spinal canal. So here on the right side of the cartoon, you see there's a normal spinal canal here, and there's no compression of the nerve. And here there is a narrowing of the central spinal canal. That is called lumbar spinal canal stenosis. Usually found in older age population, they have advanced degenerative changes, and it is more common in advanced patient population. But it can be seen in young athletes as well. In young athletes, the lumbar stenosis usually results from structural deformities like spondylolisthesis, kyphosis, scoliosis, or disc herniation. Treatment is kind of similar to lumbar disc herniation. I'm sorry. Okay, sorry, I missed a slide. The presentation of lumbar spinal canal stenosis. So usually patient presents with persistent low back pain, may or may not have radiating pain going down to the leg. Pain worsens with the activity like walking or standing, and pain improves with the forward flexion and sitting down. Patient may have dysthesias or paresthesias in non-dermatomal distribution. For example, if they have stenosis at L1, L2, they may have paresthesias and myotomal weakness, everything below L1, L2. So that would be L3, L4, L5. On examination, examine for kyphosis, scoliosis, that is any abnormal curvature of the spine. Examine for any gait changes. Patient may or may not have sensory or motor changes. On the right side of the picture showing the spinal canal stenosis, this is the shopping cart sign, where patient usually complains that when they lean on the shopping cart, meaning that when they do forward flexion, the pain gets better. Diagnostic imaging, again, X-rays can show the advanced degenerative changes, doesn't show the soft tissues. MRI is again the diagnosis of the choice, diagnostic imaging of the choice, and the CT scan. I'm sorry, something went wrong with my computer. All right, sorry about that. So here on the top image, this is the MRI. It's shown as axial cut. Bottom one is the CT scan. You can see the MRI shows the central canal better than the CT scan. Now there are three grades of lumbar spinal stenosis: mild, moderate, and severe. Mild is 75 to 99% maintenance of the AP dimension of the central canal. Moderate is 50 to 74% maintenance of the AP dimension of the central canal, and severe is less than 50% maintenance of the AP dimension of the central canal. Treatment is somewhat similar to lumbar spinal disc herniation. like rest from activity, take anti-inflammatories, and then progressive therapy with return to play. And epidural steroid injection can be helpful. Surgical treatment like laminectomy can be helpful for this kind of pathology as well. I want to go briefly into the interventional pain management. This is what I do on a daily basis. These are the epidural steroid injections. They are used for either lumbar disc herniation or spinal canal stenosis. There are mainly three approaches. One is posterior interlaminar approach, caudal epidural, and transforaminal. In posterior interlaminar approach, there is one needle that goes right where there is a narrowing. Right here in this picture, where you can see this blue dye, it looks like this is a medication. And right here, it is shown that right side of the nerve root is compressed, and you deposit steroids there, and that can help with the pain. I do this procedure under X-ray guidance. So this is the X-ray picture of the patient's lumbar spine. Patient lies on the stomach, and I look at the X-ray, clean the bag, and put the needle and deposit steroid injection there. This is just another view of the X-ray. These are all the safety measures that we need to take before I inject the steroids. This is a picture where showing that I've injected the dye into the spinal canal, and that way I know that I'm in the right spot. You can see that all the dark color, black color is the radiographic contrast. Here in the lateral view, there is a nice flow of the contrast. That means I'm in the right spot. And inject the steroid, two types of steroids. There are no difference in the steroid according to randomized control trial. Usually volume of the injected I use would be 5 to 7 ml, like 3 to 5 ml spreads, median of 2 segments in the lumbar spinal canal. This is just a different type of approach, which is called caudal epidural steroid injection. I would not go into the detail of the injection. But here, and this is a picture of the spine. This is the sacral hiatus, where needle goes from below to up. I usually do this injection for patients who had low back surgery, and I cannot go where the surgeon operated. So this is the needle going from bottom to up. Another picture from the lateral view of the X-ray, where a contrast is injected. Here is a dark color is a contrast. That means I'm in the right spot, and I inject steroids. This is a third type of approach. It's called transforaminal epidural steroid injection. Here on the right side of the picture, you can see the needle goes right where the narrowing of the foramen and where the nerve roots come out. So you can have narrowing of the foramen from the disc herniation, from the facet joint arthropathy, and you deposit steroids right where there is a narrowing is. What steroids do is steroids are anti-inflammatories. So from all the compression of the nerves, there's inflammation, and steroids take the inflammation away. Also, from the pressure from the injected, they wipe away the inflammation away from the nerve root. These are I will just quickly show you. These are the X-ray pictures of the transforaminal approach. Again, patient lays on the stomach. This is the X-ray picture. Here is my needle, and this is one of the side view from the X-ray. And the black color, this is the needle. The black color is a dye, and you have nice nerve root spread as well as the epidural spread, meaning that I'm in the right spot, and I would inject steroids then. The big question is return to play. When to return to play after athlete had pain related to lumbar disc herniation or lumbar spinal canal stenosis. So there's no answer. There's no evidence. There's no evidence regarding when to return to play after all this injury, regarding it is a C-spine or thoracic spine or lower back. But there are guidelines based on expert opinion. So as a rule of thumb, there are 4 fundamental criteria that must be met for a player before returning to playing the sport. Number one, athletes should be pain-free, have full range of motion, full strength, and no evidence of neurologic injury. The studies reported that 79% of the athletes with disc herniation returned to play following conservative therapy in an average time of 4.7 months. 85% of those treated with surgically returned to activity in average time of 5.2 to 5.8 months. Now, return to play after 2 to 6 months is possible for contact sports after percutaneous discectomy or microdiscectomy. And these are the minimally invasive surgeries, so it's okay to go back to play according to expert opinion from 2 to 6 months. Athletes with herniated lumbar disc should rest 6 to 12 weeks following surgical treatment, while those with spinal fusion, those who had instrumentation, should wait 1 year to return to activities. And many surgeons advise against return to contact sport ever following the spinal fusion. Also, as a general rule, athletes should wait until there's an X-ray showing evidence of proper fusion, complete or nearly complete relief of pain, and achievement of more than 80% strength, flexibility, and endurance of spinal muscle and spine before they return to previous activity level. I want to show you briefly the cases that Dr. Henny and I shared. I had two athletic patients, which Dr. Henny sent to me for injection. So case number one, I had a 16-year-old softball player had a low back injury during the play, started having pain in the lower back radiating to right buttock, mostly on the right side, all the way up to the ankle. We obtained MRI, which shows annular tear at L5S1 and neuroforaminal stenosis, meaning nerve compression on the right side at L4, L5, and L5S1. She underwent, I saw her evaluated. I did right L4 and L5 transforaminal epidural steroid injection on March 24th. Patient had 80% pain relief after the epidural steroid injection. She's still experiencing pain relief. She was able to go back to running. I'm sorry, my screen just went blank. I apologize for that. So this patient had 80% pain relief after the epidural steroid injection. Patient went back to running and exercises. She's currently playing softball with dad, of course, not in the school due to COVID-19 situation, without much discomfort. Another patient I had was 21-year-old female with past medical history of left hip arthroplasty, type 1 diabetic. This patient was also involving in school sports and cheerleading. She started having low back pain relating to bilateral buttocks after the left hip arthroplasty. We obtained MRI, which showed annular tear at L4, L5, and facet arthropathy. I did bilateral L4 transforaminal epidural steroid injection in February. Patient had complete relief of symptoms for 1.5 months, and then pain started coming back, but pain was not as severe. So I'm currently monitoring the patient closely, and if needed, I will inject one more time. Let's switch gears to different pathologies: spondylolysis, spondylolisthesis. Spondylolysis. The definition is discontinuity in pars interarticularis of the articular pillar. What is pars interarticularis? That's a big question. So let's look at the anatomy here on the right side. This is the anatomy of the thoracic vertebra, where you have the lamina, you have the spinous process, transverse process. This is the lamina. This is the pedicle. So pars interarticularis is a small bone segment of bone between the facet and the vertebral body itself. Right here it is shown in the red. And here it is shown that there is a stress fracture. This is a sagittal view, stress fracture shown here. Spondylolysis is usually bilateral, most commonly occurring in lumbar spine at L5, about 85 to 95% of cases, and L4 is the second most common site to be affected. Spondylolisthesis. Spondylolisthesis is the slippage of one vertebral body over one below. The reasons for spondylolisthesis could be secondary to bilateral spondylolysis, birth defects, trauma, or degeneration. Here on the right side of the picture, you can see this anterior slippage of L4 vertebrae on L5. The classification of spondylolisthesis. So it is classified into 5 types. On the right side of the screen, if you divide the vertebral body into 4 equal parts, each part would be 25%. 1, 2, 3, 4. So grade 1 is less than 25% slippage. Grade 2 is 25 to 50% of the slippage of the vertebra. Grade 3 is 50 to 75%, and grade 4 would be 75 to 100%. And grade 5 is spondyloliptosis, meaning complete detachment of the vertebral body from the level below. Epidemiology. So spondylolysis and spondylolisthesis are seen in 6 to 8% of the general population, but in young athletic population, the prevalence is 47%, very high prevalence. The increased risk is associated with sports in which it subjects athletes to repetitive hyperextension and rotation across the lumbar spine. Studies shows that its prevalence of spondylolysis in divers, wrestlers, and weightlifters was approximately 43, 30%, and 23% respectively. And it was 27% in throwing athletes and 17% in gymnasts and rowers, pretty high prevalence. Etiology. So exact cause of spondylolysis currently remains unclear, but it could be hereditary or acquired as a result of repetitive stress to lumbar spine. In young athletes, when spine is growing, when they're skeletally immature, it gives rise to multiple ossification centers, which leaves points of multiple weakness in the spine, and this leaves athletes, particularly those who are exposed to repetitive hyperextension and rotation of the lumbar spine, very susceptible to the injury and development of spondylolysis. History and physical exam. How is it presented? Usually, patient presents with focal low back pain. It could be dull ache that can become sharp on the movement. Pain may radiate to bilateral buttock or proximal lower limb. Usually, this kind of patient presents with insidious onset after the traumatic event. Pain could be progressively worsening, associated with hamstring tightness. Symptoms often worse with exercises, and when they rest, symptoms go away. On physical exam, you may not find any tenderness in the lower back on palpation. Flexion does not cause pain. Range of motion can be full. Neurological assessment should be usually normal because there's usually no nerve compression unless there's spondylolisthesis or unless there's any additional pathology present. You can see patient may have muscle spasm of the paraspinal muscles and can have increased curvature, that is hyperlordotic posture. You can do the provocative test, which is one-legged hyperextension maneuver. Patient should have reproduction of pain during this maneuver. So during this maneuver, like it is shown on the right side of the screen, patient stands up on one leg and try to do the extension of the spine, and that should cause the pain. This test is not very specific to the spondylolysis. Spondylolisthesis, how does it present? So patients usually have episodic low back pain, may have history of like pain going on and off since years. Pain usually worsens with mechanical lower when as they're going from supine to erect position or from sitting down to standing up position. Usually occurs over the course of the day, may radiate into the legs, into the thigh, may or may not have neurological signs and symptoms. The most probable sources of signs and symptoms related to degenerative spondylolisthesis are due to degenerated and subluxated facet joints, segmental instability that can cause tension of the facet joint capsule and ligaments, as well as overuse of the stabilization muscles. And there may be spinal stenosis or neuroforaminal stenosis from the shift. Diagnosis, there is no specific diagnostic tool, but along with histophysical exam and imaging can diagnose very easily. Imaging, the initial diagnosis of choice is X-ray. In X-ray, you can see the bones very well and you can see the defect, but only 30 to 38% of the defects are seen on X-ray. The another diagnostic tool is CT scan followed by MRI. So here on the lateral X-ray, on the first picture, you can see the defect. Oblique X-ray, you can see the intact pars interarticularis. And on the third picture here, you can see the discontinuity in the pars, and there's a defect there. Like we discussed, CT scan is the diagnosis of choice because CT scan shows bones very well. So here on the both side in the first picture, there is a discontinuity in the pars. This is spondylolysis. Here there's a discontinuity. The third picture is showing MRI. And the benefit of MRI is it may show other pathologies associated with low back pain, especially if there's like soft tissue damage from the shift, or if there's any spondylolysis, if there is any nerve compression, then it can show it very well. Here's the MRI picture of spondylolisthesis. This is the sagittal view. This is the T2 sequence. And there's a shift of L5 vertebral body due to degenerated changes in the disc at L4, L5. So treatment. So treatment mainly is period of rest and activity modification along with lumbosacral brace, and then gradually progressing to physical therapy with goals of like restoring range of motion, stabilize and strengthening the spine and core, and reduce pain. So it is very important to start with periods of rest or like minimize the activity, wear the brace for 8 to 12 weeks, and then move to physical therapy as tolerated. Electrical modalities like e-steams or stents unit can be useful as well. About 94% of the patients who have like mild spondylolisthesis can get better with this kind of treatment. The surgical treatment is the repair of the fracture itself, repair of the fracture, or posterolateral fusion where they put screws and plates which fixes the bone and there is no movement in the bone where there was a shift or fracture. Return to play. Again, lack of evidence regarding optimal time of return to play based on expert guidelines. Patients with spondylolysis and spondylolisthesis, which is grade 1, should rest for 4 to 6 weeks and then demonstrate full range of motion before and pain-free before they return to play. For spondylolysis, the guidelines do not recommend contact sport after fusion for spondylolysis. But there's a survey of 261 patients from Scoliosis Research Society members. They found that about 27 to 36% of surgeons allow this patient to return to collision sports 1 year postoperatively. So the fusion of the spondylolysis is not always a contraindication to return to contact sports, but the time frame for return is variable. For spondylolisthesis, the criteria vary among the surgeons, but as a general rule, pain-free range of spine motion, absence of any neurological deficits, evidence of good bony fusions on imaging are the consideration before return to play. And patients who had like posterolateral fusion for spondylolysis and spondylolisthesis, they have had good outcomes in terms of like being pain-free and returning to the play. Now, returning to the play, contact sports is feasible after direct pars repair because there is no instrumentation and which preserves the spiral motion in athletes with these conditions. Now, let's switch the gears to different kind of pathology, which is called lumbar facet-mediated pain. Epidemiology accounts for 5 to 15% of chronic axial low back pain. Arthritis is the most common cause of pain coming from facet joint, and its prevalence increases with the age. Most frequently, the painful joints are the lower lumbar joints, followed by upper lumbar joints, which is L5S1, followed by 4, 5, and 3, 4. This kind of pain is common in athletes like baseball players, especially pitchers where they have to hyperextend and rotate, hammer throwers, and tennis players. This is a picture showing the facet joint. So facetogenic pain is the pain that arises from any structure that is part of the joint itself. It could be fibrous capsule, it could be synovial membrane, hyaline cartilage, or bone itself. So anatomy. So facet joints are the paired structure located in the posterolateral portion of the vertebral body. It's usually made of here on the right side of the screen, showing the facet joints. So usually made up of superior articular process of the one lumbar vertebra and inferior articular process of the level above. So this is a picture showing the arthritis-like changes in the facet joint, and this is a normal facet joint. Now the facet joint is a true synovial joint. It has fibrous capsule about 1 millimeter thick, which provides resistance to flexion. The facet joint serves primarily protective role by limiting the motion. So you have limited motion, and that's how it protects the whole spine. It carries about 3 to 25% of axial burden when you're standing. Innovation. So this is a very important information for physicians because this information is helpful for the treatment. So facet joint is receiving two nerves supply. The nerve that is supplying the facet joint is a medial branch of the spinal nerve. So each facet joint is supplied by the nerve at the same level and the nerve from the level 1 above. What are the common causes of having facet joint pain? So acute trauma after rapid deceleration injury like traffic accident. It is more common in the neck after whiplash injury, common to have the chronic pain related to the facet arthritis. Regular wear and tear, it is one of the most common cause of the facetogenic pain. It could be inflammatory arthritis like rheumatoid arthritis, ankylosing spondylitis, or reactive arthritis. And the synovial cyst, sometimes the cyst arises from the facet joint putting pressure on the surrounding structure and cause the pain. So pathology. So here on the right side of the picture, you can see the normal joint over here in the center. So from repetitive stress and low-level trauma, there is inflammatory cascade starts in the vicinity of the facet joint that can cause the fluid accumulation and swelling of the joint itself, followed by joint capsule stretch, and the capsule stretch can cause axial pain only. If this capsule stretch along with the inflammatory changes causes osteophytes and putting pressure, here like it is shown over here on the nerve root, it can cause pain going down to the leg. It can cause reflex spasm of the paraspinal muscle, starts peripheral and central sensitization, and goes to chronic pain mode. How are they presented? So usually presented with axial low back pain. They may have referred pain plus or minus radicular symptoms. Radicular symptoms are very less likely though. Upper lumbar facets are referred to flank, hip, and upper lateral thigh. The lower lumbar facets are referred to posterolateral thigh and calf. and very rarely you see pain going distal to the knee. They are usually presented as osteoarthritic-like symptoms, especially in the old age. They present with deep, dull ache, progressive rather than acute pain, usually feel stiffness in the morning, pain relieves with the rest and worse with the activity, and as day progresses, they can feel better. They may, on physical exam, they may have vertebral tenderness and facet loading. If you put when they are standing, if you put pressure on the shoulder and ask them to bend on one side, that can cause the pain, and that's one of the signs of facetogenic pain. Diagnosis, how would you diagnose? So sorry, this is a very busy slide, but the point of having this slide is clinical manifestation is vague and hard to differentiate. So there is no way to tell for 100% that this is a facet-related pain. These are all studies from 1981 to 2006. They studied like ability to predict from lumbar medial branch block to see what this patient usually have presentation in the pain. And the specificity of clinical presentation is poor. The most reliable method for determining facetogenic pain is image-mediated medial branch block. So if you do the block of the nerve that supplies the facet joint, and if you have relief, that's the only reliable method of saying that this pain is coming from facet joint. Imaging ranges all the way from X-ray to SPECT-CT. They can have facet arthritis seen on the images, but the specificity and sensitivity is very, very low. The treatment, so no conservative treatment specifically evaluated for facet pain, and pharmacotherapy only works modestly for this kind of pain. But still, the physical therapy is the first thing to go. So simultaneous rehabilitation of the core, muscle strengthening, and this lumbar spine stabilization, trunk or thorax rotational mobilization are recommended. Medication-wise, anti-inflammatory medications, opioid, antidepressant, gabapentin, these are the pharmacological treatment that have shown modest benefit. And the interventional treatment. So interventional treatment is facet medial branch block. Like I discussed before, the facet joint has two nerve supply, one from the level at the same level and one coming from the level above. And what you do in the facet medial branch, you go under the X-ray and deposit numbing medication, which is local anesthetic, right where the nerve resides. The block is positive if patient has more than 50% reduction in the pain for the duration of the local anesthetic. But this treatment has a high chance of false positive rates, 25 to 40%. If you use like higher volume for the injection, or if you give sedation, then there's a high risk of having false positive rates. So for that, you can avoid the sedation for this kind of patient. You can just inject minimal amounts of medication, just stays where the nerve resides and does not go around in the area, and can help. If facet medial branch block helps 50% or more, then there's the procedure which is called radiofrequency denervation, where you put needle where the nerve resides and kind of give electric signals and burn the nerve fibers that stunts the nerve, and that can provide pain relief anywhere from 6 to 9 months, so which is a long-term pain relief. Return to play, again, no specific criteria found. In general, achieve full range of motion of spine and at least 80% of the muscle strength before returning to play. Any questions?
Awesome job. Well, thank you so much for giving this presentation. I do appreciate your time. I'm going to go ahead and start running through questions here. And so the first question that has come up is in regards to for these athletic trainers who are sending who are maybe on the sidelines, or one of their athletes is coming into the training room and presenting for low back pain. The physical exam tests are difficult to be able to hone in on exactly what the diagnosis is. And this first question is about physical exam techniques. What are your go-tos when you're talking about different diagnoses? How do you start? What's kind of your pearls and pitfalls as you examine the back?
Very good question. So my go-to for before I go to the physical exam, I spend good amount of time evaluating history and ask patient question that since how long patient has been having pain, what are the symptoms what are the symptoms specifically in terms of, is it only pain? Does pain going down to the leg? Is there any weakness? Is there any history of urinary incontinence? So rule out the red flags. Then go to the physical exam. I check for the tenderness. First of all, I check for the gait. I look at the actual back and see if there are any lesions or anything or redness. And then I do the provocative test. Also, I always rule out the neurological symptoms. So I check for sensations to cold, to warm. I check the motor power of the leg, and once I rule out that, I rely on the provocative test highly for the low back pain to diagnose, and then talk to my patient.
Awesome. Yeah, I know it is definitely a struggle in terms of, let's say, if you've got someone you're trying to see, is it a lumbar strain or is it a disc, for example? And you're putting them into flexion and they're talking about pain. They may not have radiating symptoms coming down the back, but they are having kind of that centralized pain. You've gotten x-rays, nothing really conclusive showing up. How do you go about differentiating the lumbar pain strain? Because they both probably, let's say it's a football player, they both probably had a mechanism that they're going to tell you about. How do you go about differentiating those two?
Well, so if there's if everything is inconclusive, then I would also there is another way to see if the pain, chronicity of the pain, if pain is on and off, or like some tingling numbness in the leg. My major go-to when I approach this kind of pain is to rule out if there's a signs of nerve compression. So even if they don't have pain going down to the leg, but if they have tingling numbness in the leg, they can be suggestive of the nerve compression itself, lumbar disc herniation itself. If everything is inconclusive, then I order imaging test anyways, because I want to rule out, and especially if it is an athlete, we want to make sure that we check all the points before we let athlete to go back to play. So in that case, I use imaging portion of it and see. I order X-rays first and then order MRI. If X-ray is pristine, I mean X-rays do not provide that much information, but you can see the like a narrowing of the joint space in between the vertebrae. Then you can tell that this patient may have like disc herniation or central canal stenosis, and then order MRI.
Awesome. Okay, and so I have a question here from Mick about how long after injection would you have someone initiate rehabilitation and therapy?
Very good question. So I usually, for athlete, I have like different kind of patient populations. So especially for athletes, I ask them to rest for about 2 weeks, because steroids takes about 5 to 7 days to kick in. they may have pain for first few days after the injection, and then they slowly work. So about at 2 weeks mark, they will have relief if they were to experience any relief. And then once they're relieved, they can go back to like activity slowly. Because this is similar, my injection, this is how I think. My injection is not going to cure that problem. If they have discontinuation, I'm just putting patch on it. I'm not treating the discontinuation, I'm treating the pain. So if they tried physical therapy before my injection, and if I did the injection, and if they're relieved, there is no point in like waiting for 4 to 6 weeks before they can go to physical therapy. So about 2 weeks, and I take it like I see how they feel after 2 weeks. If they did not have any relief, then I may need to change my treatment plan. And they go back to like the case reports I had, they go back to being like slowly increasing the activity. If they're runners, they go back to running. Not too much weightlifting for first 4 weeks, because I don't want discontinuation to exacerbate. And then if the pain comes back in 8 weeks or so, I always repeat the injection in that case.
Gotcha. Let's say, because I know the athletic trainers I work with, they love to reach out to me at all times, and they want to know what if they have their injection and they are now pain free, can they start some things with their athlete while they're waiting on that 2-week mark with you? If we're mid-season and we're thinking we're going to be trying to get them back for more of the season, we don't want them to lose too much of their cardiovascular fitness. What would be your response?
I would still wait for 2 weeks. In my like current experience, I think I would still wait for 2 weeks and then go back. And
at that 2-week mark. Awesome. All right. So I have a question here from Dovin. It's how to differentiate between a burner and an actual spinal cord or nerve injury.
So, can you repeat the question?
Yeah. So the stingers and the burners, which are those brachial plexus transient nerve injuries, differentiating, how would you differentiate between those are the football players that kind of come off, they're shaking their but symptoms tend to resolve. How would you differentiate between those and a spinal cord or nerve injury?
So that is a very good question, and this kind of pain is very difficult to differentiate because brachial plexus and the cervical plexus, so brachial plexus originate from the cervical plexus, and they both run down to the hand. So kind of like from history and physical exam, see if they have any neck pain, see if they have any headache associated with it, and that can tell you kind of pain that is coming from the neck. If you do the examine the shoulder, and if their movements are painful, that can be the brachial plexus. If at some point it becomes confusing, always order MRI, because for neck, I do not touch the neck without imaging. Do not touch, meaning do not do any intervention for the neck without imaging. So I think imaging is the best way to differentiate between the pain coming from the neck or from the brachial plexus.
Yeah, and I know, standing on the sidelines, I know that sometimes clinically you can follow along based on, is this unilateral or bilateral? If there's bilateral, I'd definitely be looking more at a central cord issue. And then also if it tends to resolve fairly quickly. If this is persistent more than 5 or 10 minutes, then I start thinking, okay, we may want to get this kid in, first thing the next week, if it's on the weekend, or kind of depending upon those.
Absolutely. I agree. Absolutely. Thank you.
Awesome. Well, thank you so much, and I appreciate you speaking with us today. This is a really good topic, and I know that for a lot of the athletic trainers, you're on the sidelines, you're seeing these kids run off all the time, and you're trying to differentiate what might this be. So I know that this is going to be very valuable for those that have attended. All right, I hope everyone has a great day and stay safe out there.
Thank you, and thank you for giving me this opportunity, and it was a pleasure to be here today. And stay safe, everybody. Take care.